To give you context in the video that you're going to see next, there were 800,000 strokes in America, and there were 200,000 strokes in Canada. There were more than 1 million in Europe combined, and 12 million overall in the world that were documented. Strokes are not the only neurological client that we're going to talk about, but you can include brain injury, spinal cord injury, and surgical injuries to the L4, L5, S1, S2, S3 complex. And what you're going to see is that a lot of these patients, probably 30–40% of stroke patients have a supinated foot when they walk. During swing phase, the foot supinates due to the anterior tibialis not working and the posterior tibialis drawing the foot into supination. When a patient is walking with supination like that, they land on the outside of their foot, and it's like they're going to twist their ankle. Right now in our industry, in prosthetics and orthotics, we don't have anything that controls the supination except for a Velcro strap. That's it. Now, I've developed a device that attaches to AFOs, ankle-foot orthoses, that will control the supination and hold the foot straight. By putting pressure on the talus bone and preventing it from rising into supination, I'm able to manage a straight foot and a flat foot when they walk. Hi, my name is John Erdman. I'm an ABC certified prosthetist, and this is Bonnie Jenkins Close. She's a former physical therapist for 40 years that specialized in neurological gait deviations, i.e. stroke patients. And together, 15 years ago, we came up with a design that actually reaches from the lateral side of an AFO up to the talus bone and puts pressure on the talus bone. The design that we have looks like this. This is the base plate where it attaches to the AFO. And then you take, when this is hot, you take it and you wrap it up over to the talus bone, and then it cools off in that position. There'll be a Kevlar sock underneath so that the patient doesn't get burned. But Bonnie's going to speak towards the function of it.
So what we notice is that if the talus was supinating, it blocked the tibia from the forward progression, which interfered with transitional functions and didn't allow the foot to dorsiflex because the talus was blocking the tibia from moving. At the time, most people assumed that it was the hind foot that was tight, the Achilles. People kept, stretching out the Achilles, when in fact it was the talus supinating. So this comes lateral to try to capture that talus after you mobilize it, perhaps, to keep it down in its neutral position to allow the tibia to go forward so the foot doesn't supinate, for better balance, for increased heel strike, for foot flat, and hopefully to decrease the toe drag, the foot drag, primarily seen in strokes.
So once you're fabricating this and you use an off-the-shelf AFO like this one, you go ahead after it's cooled off and in position, you find the correct position and you speedy rivet the device to the bottom of the AFO like that. Later on, we're going to show you with a live patient how this works and can explain the different gait deviations. This is our live patient, Steve. Steve had a surgery that nicked the nerve and caused drop foot, supination, and some mild rotation. We're going to take a look at Steve walking without a brace, and then also with a brace and AFO with the supination device mounted on it. You'll notice that the line that I drew on the back of his heel, bisecting his heel, inverts without the brace. And then you'll see that the line is perpendicular to the floor with the brace and device. Now let's do our test.
Briefly, you can see that Steve has excessive external rotation in standing on his left lower extremity, which is his weak side. He doesn't have the brace on. You can see the excessive supination in his foot throughout and foot slapping when he contacts the ground. From the side, you can see that he does have excessive knee hyperextension. The foot remains supinated throughout the entire stance phase, and he never achieves full dorsiflexion at the ankle as the tibia remains backwards. From behind, you can see the line is somewhat lateral, demonstrating his supination. In slow motion, you can even appreciate the supination even more as he swings through the lateral border. It contacts first, and the foot drops hard to the medial side. You can anticipate that the sound would be a significant foot slap at this point. Of note, Steve does have full range of motion throughout his knee and foot, except he does have stiffness of the first ray. Standing with the brace on and the supination device, somehow Steve's base of support is significantly less. His hip external rotation, he may be more aware of, but he seems to have fixed it a little bit better. He continues to have external rotation throughout swing with excessive use of hip flexion to clear, but his heel strike is more consistent, especially from the side. You can see he does have a heel strike to foot flat, although the tibia never really fully progresses forward over the talus, but his gait speed has improved. He continues with external rotation. You can see it significantly as he increases speed. In slow motion, you can see a significant improvement. The calcaneal line is more vertical. He continues to demonstrate a slight wobble as he goes from late swing to initial contact, and that could be from his hip external rotators overfiring, although he does have an increase in heel strike with a progression over the forefoot. His knee is slightly flexed there in that final turn, and the external rotation is still prevalent though.
In conclusion, the device is going to be applied by a certified orthotist so that the certified orthotist can find the right anatomy, the talus bone, and it's going to be supplied through SPS and Cascade, which is the orthotic and prosthetic suppliers for North America. The device is going to come in 3 different sizes: small, medium, and large, and left and right. Again, it's going to be a flat piece of material in this shape, and the certified orthotist is going to warm it up and then fold it over to the talus bone and let it cool in that position.
So we'd really like to thank you for listening to our video and seeing it, and hopefully you'll be encouraged by the device. We invite you to comment below, and we'll do everything we can to get back to you as quickly as possible. Thank you again.
Thank you.